All right, let's dive into something that I think every endocrinologist will find fascinating. Pituitary apoplexy, or PA.
Mm-hmm.
And we're going beyond the basics here. We've got a new study fresh from the journal Pituitary where they looked at 93 cases all from a single center in India. So consider this your deep dive into what's really important about PA, especially for those of us on the front lines treating it.
You know, one of the things that struck me about this study was how it challenges some of our traditional thinking about PA, particularly when it comes to how we manage it. There are some real surprises here, things that might make you rethink your approach to these cases.
Okay, so before we get into the details, let's make sure we're all on the same page. What exactly is PA and why should endocrinologists be particularly tuned into it?
So picture this. You've got a pituitary adenoma, but it's been growing silently, maybe not causing any obvious hormone problems. Then suddenly, bam, there's bleeding or a clot within the gland. That's PA in a nutshell. And the really interesting thing is for about 80% of people, this is the first sign they even have an adenoma.
So it's not always this slow, predictable thing that we can monitor. It could hit a patient and us as their endocrinologists out of the blue.
Exactly, which is why understanding PA is so critical in our field. Now, this study found that the overall prevalence of PA was 4.76%, pretty much in line with what we've been seeing in the literature.
Not a daily occurrence, but definitely something we need to be aware of.
And here's where it gets even more interesting for us as endocrinologists. The prevalence jumps to 9% when we focus on non-functioning adenomas.
Wait, so those quiet tumors, the ones that aren't messing with hormones, are actually more likely to have this sudden serious event. That kind of flips the script on how we think about these patients.
It does, doesn't it? It raises the question, how can we be more proactive in detecting these non-functioning adenomas before they reach this crisis point? Are our current surveillance strategies enough?
Okay, so we've got this higher risk with non-functioning adenomas. What about the patients themselves? Anything unusual there?
One thing that stood out was the age. The median age of onset was just 40 years old, which is younger than what's usually reported.
Is that a trend we're seeing more broadly, or is it specific to this study population in India? Makes you wonder if there's something we're missing, or if our understanding of risk factors needs an update.
It's a good question, and to be honest, this study alone can't answer that. But it definitely highlights the need for more research in this area, especially as our patient demographics might be changing. Now, moving on to how PA actually showed up in these cases, the researchers divided them into three types: acute, subacute, and non-acute.
So a range of severity from drop everything, this is an emergency, to something more gradual.
Exactly. Almost half the cases were acute, needing immediate attention. But then you have those subacute cases developing over days or even weeks, and even non-acute cases with milder symptoms that emerge over longer periods.
I can see how those less traumatic presentations could be easy to miss, especially if we're not thinking about PA as a possibility.
You're absolutely right. Having a high index of suspicion is crucial, especially when we see patients with certain risk factors, or even vague symptoms that might not scream pituitary. Early detection can make a world of difference in these cases.
Okay, so early detection is key, but the study also found that it was surprisingly hard to figure out what actually triggered the PA. They could only pinpoint a cause in about 5% of the cases.
That's incredibly low. It really speaks to how unpredictable this condition can be. We know some of the usual suspects: head trauma, certain medications. But in many cases, PA seems to strike without warning.
So vigilance is really our best weapon here. We can't always rely on obvious warning signs because they might not be there. Now, the study also looked at differences between functioning and non-functioning adenomas, and they found some pretty interesting patterns there.
Let's start with the non-functioning adenomas. This study found they were more likely to have cranial nerve deficits and hypocortisolism as well.
So not only are they more likely to show up with PA as their first sign, but they're also coming in with more complications. What's going on there?
Well, think about it. If a tumor isn't causing any noticeable hormone problems, it can grow larger and become more invasive before we even know it's there. By the time PA happens, it might already be affecting nearby structures like those cranial nerves.
Right, so it's a silent but aggressive threat.
Now, on the other hand, the functioning adenomas in this study tended to be larger overall, but that was mostly because there were a lot of giant prolactinomas in the mix.
Giant prolactinomas. Wow. How does that affect our management approach when PA enters the picture?
That's a great question. And that's exactly where we'll pick up in part 2 of this deep dive. We'll untangle how this study tackles treatment strategies and whether our traditional assumptions still hold up.
Can't wait to get into that. We'll see you back here soon for part 2.
Welcome back to our deep dive into PA.
We left off talking about those giant prolactinomas. I mean, for an endocrinologist, you see that and you automatically think treat with cabergoline.
Yeah.
But with PA in the mix, it's not so simple, is it?
You'd think so, right? But that's what makes this study so interesting. It really challenges those knee-jerk reactions we have as endocrinologists. It forces us to take a step back and consider all the angles.
So, what are the big takeaways here? How does this research change the way we think about managing PA, especially when it comes to that big question, surgery or conservative management?
Well, for non-functioning adenomas, they actually found similar recovery rates in both the surgical and the conservative groups. That's pretty significant.
Hold on. So you're saying we might not always jump to surgery? That goes against a lot of what we've been taught? What are the implications there, especially for us endocrinologists who are often the ones making these decisions?
It suggests that maybe we need a shift in our thinking, moving away from a one-size-fits-all approach and towards something more personalized for each patient.
So it's not just about what the textbook says, but about really understanding the individual patient in front of us. That puts a lot of responsibility on us.
Absolutely. It underscores how important it is for us to really grasp all the nuances of PA and what factors into those treatment decisions. And remember that younger median age of onset we talked about, that plays a role too.
Right. Because a 40-year-old patient facing surgery or lifelong hormone replacement has very different considerations than someone in their 60s or 70s. It adds another layer of complexity to an already complex situation.
Exactly. And then you've got the different types of adenomas involved. We know those non-functioning adenomas were more likely to have cranial nerve deficits and hypocortisolism, which definitely changes our management strategy.
So those patients might need more urgent intervention, not just to deal with the PA itself, but also to manage those other complications. Are we talking about moving towards surgery sooner in those cases?
Not necessarily. While those complications are serious, this study reminds us that surgery isn't always a perfect solution. It has its own risks, and we have to carefully weigh those against the potential benefits for each patient. It's a tough call, for sure. But what about those functioning adenomas, especially the giant prolactinomas? How do they change things?
That's where our endocrinology expertise really comes in. While surgery might be the first choice for some functioning adenomas, especially the ones causing acromegaly or Cushing's disease, prolactinomas often respond very well to medical therapy with cabergoline.
So we've got more options, which is good. But it also means we need to be really good at recognizing the different types of adenomas and how that affects our management strategy.
Exactly. It's about understanding the underlying mechanisms and tailoring our treatment accordingly. And this study also emphasizes the importance of a team approach, working with neurosurgeons, radiologists, and other specialists to get the best possible outcome for each patient.
Okay, so we're moving away from rigid protocols and towards a more individualized approach. But this study also had something interesting to say about the Pituitary Apoplexy Score, or PAS. Remind us what the PAS is and how this research challenged our assumptions. The PAS helps us gauge how severe the PA is, based on the patient's neurological symptoms. Higher scores usually mean a more severe presentation, which often leads us towards considering surgery.
Right, so the worse the symptoms, the more aggressive we are with our approach. Makes sense. But this study found something unexpected when they looked at patients with similar PAS scores.
Yeah, even when they compared patients with similar levels of severity, the outcomes between surgery and conservative management were pretty much the same. That really challenges the idea that the PAS score alone should determine what we do.
So it's not just a simple high score equals surgery equation anymore.
Nope. It's one piece of the puzzle, but not the whole picture. We're back to that personalized approach, weighing all the different factors.
So what does this mean for us as endocrinologists? What do we do with this information?
It means we need to be thinking critically and using our best judgment. We can't just rely on a score or a guideline. We need to be looking at the whole patient, their individual situation, and the potential risks and benefits of each treatment option.
This is where our expertise as endocrinologists really matters. We're the ones who understand these conditions, the long-term implications of treatment decisions, and that balance between managing the acute event and ensuring the patient's well-being down the road.
And speaking of long-term implications, remember that this study found that 87% of patients developed pituitary hormone deficiencies after PA, regardless of whether they had surgery or not. That's a huge number.
Wow, 87%. That's a bit sobering. It really highlights the responsibility we have to these patients, making sure their hormonal needs are met for years to come.
Exactly. We're not just managing a single event, we're managing a chronic condition that could affect them for the rest of their lives. We have to be ready to address those deficiencies in cortisol, thyroid hormone, growth hormone, and sex hormones. We need to be monitoring these patients closely and adjusting their treatment as needed.
So monitoring is absolutely key. What specific hormones should we be keeping an eye on?
They found deficiencies across the board: cortisol, thyroid hormone, growth hormone, you name it. It's a lot to keep track of, but it's crucial for these patients' quality of life.
I can imagine a patient just coming out of this scary event, and I'm hitting them with a list of potential hormone problems and treatments.
Hmm.
How do we make this manageable for them and for us?
It's about breaking it down, explaining things clearly, and tailoring the information to each patient. We need to be clear and concise, explaining why we're monitoring and treating them in a way that makes sense. And we need to be there for them, supporting them, and answering their questions.
It's like we're becoming partners in their care, helping them navigate this whole complex situation.
Exactly.
Now, the study also talked about potential complications after PA, especially for those who have surgery. What are the warning signs we should be watching out for?
They saw permanent AVP deficiency, which leads to increased thirst and urination, and CSF rhinorrhea, which is leakage of cerebrospinal fluid from the nose. Both of those were observed in the surgical group.
So even after the PA itself is over, we still need to be on the lookout, especially during those follow-up appointments.
Absolutely. Regular checkups are crucial to catch any complications early and make sure their hormone replacement therapy is working properly. It's also a chance to check in with them overall and see how they're doing.
This deep dive has really given us a lot to think about when it comes to the long-term care of PA patients. It's a journey that requires our expertise, our empathy, and our commitment to providing the best care possible.
I agree. And as we move on to the final part of our deep dive, I want to leave our listeners with this thought. This study has really challenged our assumptions about PA. It's pushed us to reconsider our approaches and embrace a more personalized, patient-centered model of care.
It's a call to action for all of us in endocrinology. We need to stay up to date on the latest research, have open discussions with our colleagues, and always strive to improve our patients' lives.
That's what makes this field so rewarding, isn't it?
Absolutely. And to all our listeners out there, keep asking those tough questions, keep pushing the boundaries of what's possible, and keep advocating for your patients. That's what being an endocrinologist is all about. So, welcome back to our deep dive. We've been talking all about pituitary apoplexy. And, in the last part, we touched on that striking finding that 87% of patients end up with some kind of pituitary hormone deficiency after PA. That number really stuck with me.
Yeah, it really underscores the long-term impact this condition can have even after that initial event. And that's where we as endocrinologists really need to step up.
Let's talk about that. I'm an endocrinologist, I'm listening to this, and that 87% is weighing on me. What should I be taking away from this and bringing back to my practice?
I think the biggest thing is to shift our mindset. We're not just managing a crisis here. We're managing a chronic condition that needs ongoing care and attention. It's about being ready for those long-term hormonal needs and being proactive.
So we need to really educate our patients, right? Have those conversations about the possibility of lifelong hormone replacement, the different hormones that could be affected, how those deficiencies could impact their health down the line.
Exactly. And we need to start those conversations early, ideally when we're first managing the PA. We can't wait until those deficiencies show up. We have to be on top of it, monitoring hormone levels and adjusting treatment as we go.
Okay, monitoring is key. But which hormones are we talking about specifically?
This study found deficiencies across the board: cortisol, thyroid hormone, growth hormone, sex hormones. It's a lot to handle, but it's crucial for these patients.
I can imagine a patient just coming out of this scary experience, and I'm throwing all these potential hormone problems and treatments at them. How do we make this manageable for the patient and for us?
It's about breaking it down, explaining things in plain language, and making sure the information fits the individual patient. We need to be clear about why we're monitoring and treating them, make sure they understand, and we need to be there for them, answer their questions, be a support system.
It's almost like we become partners in their care, walking them through this whole process.
Exactly.
This study also pointed out some potential complications after PA, especially for those who have surgery. What should we be looking out for?
Well, they found permanent AVP deficiency, which causes excessive thirst and urination, and CSF rhinorrhea, where cerebrospinal fluid leaks from the nose. Both of these were seen in the surgical group.
So even after the initial PA is resolved, we can't just assume everything's fine. We need to stay vigilant.
Absolutely. Regular checkups are so important to catch any complications early on and make sure their hormone replacement is optimized. It's also a chance to see how they're doing overall, address any new concerns they have.
So this deep dive has really shown us the long road that many PA patients face. It's a journey that needs our expertise, our compassion, and our dedication to providing the best possible care.
I couldn't agree more. And as we wrap up here, I want to leave our listeners with a thought. This study has really shaken up what we thought we knew about PA. It's pushed us to rethink how we approach these cases and embrace a more personalized, patient-centered model of care.
It's a call to action for everyone in endocrinology. We need to stay informed, keep talking to each other, and never stop trying to improve our patients' lives.
And that's what makes this field so rewarding.
Absolutely. And to all our listeners out there, keep asking those tough questions, keep pushing the boundaries, keep fighting for your patients. That's what being an endocrinologist is all about.
Well said.
And on that note, we'll wrap up this deep dive. Thanks for joining us, and until next time, keep those minds sharp and keep making a difference.